All right, everybody. So on your screen, you should see where we left off last week when we were talking and just finished up speaking about DKA, hyperglycemia and hypoglycemia. Now we're going to move on to disorders of the thyroid. Again, remember where the thyroid is located directly over the trachea, approximately located within the area of the Adam's apple and the larynx. Also, don't forget that where that thyroid is located, there's also 4 other glands next to it called the parathyroid glands. These are very important in the overall homeostasis of our metabolism, as well as calcium uptake and everything else like that. A couple of the things that we need to worry about are what are known as hypothyroidism, which is low thyroid hormones, and the two hormones that we talk most about are going to be T3 and T4. T3 stands for triiodothyronine, and T4 stands for thyroxine. Now, if you noticed in T3, it says it's a triiodothyronine. Well, the triiodo is 3 molecules of iodine. That's why one of the issues that we see in third world countries are what are called goiters that tend to become enlarged because the thyroid gland, under stimulation of the brain, ends up being forced into action through the intermediator called TSH, thyroid stimulating hormone. And when there is no free iodine in the system, what the thyroid gland does is actually become larger to produce the iodine, the little bit of iodine that we need into our system. That's why Morton's you'll see in the majority of our salt in our nation, and in most culturally up-to-date scientific nations are going to use iodized salt, sodium chloride, for their table salt. That keeps the production of the triiodothyronine down to normal levels because the thyroid gland doesn't need to make its own iodine to help produce that intermediary. Most of the time with the treatment for hypothyroidism is going to be overall thyroid hormone replacement therapies. All right, individuals will be getting shots, maybe taking oral pills, something like that. And then the other one is going to be hyperthyroidism, where there's too much TSH being produced, which then produces too much T3 as well as T4. And then one of the other issues that you'll end up seeing with this is going to be calcitonin. Calcitonin can lead to bone spurs, everything else like that, and everything. That hormone helps to regulate the amount of calcium that's stored in the bones that's going to be able to be broken down and brought into free calcium throughout the rest of the system. So if you look at this, here's one of those memes that I was talking about. Here you see somebody here on the left here with hypothyroidism. All right, so the individual with hypothyroidism is going to be intolerant to cold. All right, these are the individuals that are constantly covering up because they're always cold. You'll see again, you'll see a receding hairline with this. That's where a lot of times when you assess individuals, if you see a female with an early receding hairline, one of the things they're going to start looking at over time is going to be that low T3 and T4. Facial and eyelid edema, dull blank expression, extreme fatigue constantly, because again, your T3 and T4 are going to help with your metabolism. So if you're not getting that extra energy from the T3 and T4, you're going to end up becoming extremely fatigued. You're going to have a thick tongue and a slow speech in that. And again, most people will see that, and there's the possibility of, because of that, end up becoming, people assuming because of the thick speech, some type of a neurological issue like a CVA or something like that. Patients are going to be anorexic. They're going to have brittle nails and brittle hair, as we talked about. Apathy, lethargy, dry skin, coarse and scaly muscle, constipation, menstrual disturbances in the female. And again, this is pre-menopause. And then one of the things that we'll end up seeing in late clinical manifestations of this will be subnormal temperature, usually below 98.6. Individuals who are bradycardic. Some individuals, despite the fact that they are anorexic, later on may get a weight gain with that, thickened skin, and because of the issues here, weight gain, bradycardia, and the temperature may end up with some cardiac complications. On the flip side of this, we're going to have the individuals that are suffering from hyperthyroidism. Again, too much of a good thing. But again, with this too much of a good thing, what we'll end up seeing here is here they can't tolerate the heat. They're constantly too hot. Just the opposite of the hypo. You'll see some finger clubbing in that because of the overt growing of the tissue down there. Most of the time, this may coincide with somebody with COPD, along with the smoking issues. Again, menstrual changes in this issue, the amenorrhea, lack of a menstrual cycle, again, premenopausal, all right, with these individuals very, very thin. You'll see the bulging eyes. If you see somebody with bulging eyes, typically they do have a hyperthyroid issue going on. Their hair becomes very fine and straight, tachycardic. Again, the exact opposite of what we just talked about here with the hypothyroidism, all right? So you'll end up seeing all these issues going on with these patients. Most of the time, we're not going to end up having to treat these people for their root cause of the hypo or hyper, but we should know that with individuals that do have a history of hyperthyroidism, there is a condition known as thyroid storm, and a thyroid storm is just a massive increase of a release of T3 and T4, which causes actions of hyperthyroidism, anxiety, and all that other stuff that moves along with that. But these are something, again, that, along with your some of the DKA stuff when it comes to the endocrine system are hit a couple of times in your national registry situations. One second, let me clear all this. Some other issues that go along here with individuals with this is going to be GI issues as they get older. And again, these individuals, due to neurological issues, may have frequent emergent bladder releases as well as bowel releasing. And because we talked about upper and lower GI issues, there may be bleeding associated with that. Nausea, poor appetite, diarrhea, constipation, all goes hand in hand with what we just talked about. Most of the time, these individuals, unless they're actively bleeding or something like that, they have them under wrap. These individuals, you would hope, would avoid drinking red type of liquids like fruit punch or anything else like that. That way you'd be able to tell the difference between an active bleed or something that has been digested within the system. But whatever the issues are, is if we have an active bleed or something like that, we still start with the ABCs. We take care of them, check their any cardiac issues, do pretty much everything we do, start a line, just in case we do need to get a little bit of fluid to increase that cardiac output, and potentially end up, if they do, they are actively bleeding, they go to the ER, they end up getting blood levels, find out they're extremely anemic, then they need a line to go ahead and start possibly giving a unit or two of packed red blood cells and or whole blood in that. Some other things that you're going to see with the GI issue there is going to be Crohn's disease. This usually goes hand in hand with individuals that have hyperthyroidism, just because the metabolism is moving very, very quickly, and they're anorexic, very thin, potentially therefore, the larger weight gain. But again, familiar tendencies, you'll usually see the peak on this of 15 to 40, but it can extend beyond that, especially in the female population. There's questionable regards to autoimmune issues with this, but again, typically these individuals will be very thin, wasting away almost. You'll see them coincide with the hyperthyroidism with the large bugging eyes, as we just talked about, the bloody stools, the weight loss, the inability to maintain normal thermal regulation. All right. Patients will complain to you abdominal pain, distension, tenderness in the right lower quadrant. And again, if we're worried about that right lower quadrant, that's where your ileocecal valve is. That's where it's moved from the small intestine over to the large intestine. And again, we'll have excess water, but also in that right lower quadrant, right around that area that we refer to as McBurney's point, that's where we're going to end up potentially have we'd have to rule out acute appendicitis upon assessment of the belly. If we touch down there and it feels like they're a scalded cat jumping away from you. You can think about Crohn's disease and think about the history, but if it's quite acute and everything else like that, and they don't have a known history of Crohn's disease in that right lower quadrant, then you want to go ahead and consider possibly appendicitis. Some other things that can also go on due to this issue down there is intra-abdominal abscesses, interstitial fistulas, peritonitis, development of fistulas, and a fistula is outpouring of the intestine, which becomes larger and larger and larger, almost on the aspects of like an aneurysm, where those fistulas can fracture, which then leads to the bleeding and the bloodied stools. Some other things that we'll see here: upper GI bleed, versus a lower GI bleed. Upper GI bleed also can be known as peptic ulcer disease. Basically, the mucus lining of the GI tract from the esophagus down into the stomach becomes opened, and with that, with the secretion of the chief cells, the releasing and the creation of the hydrochloric acid, basically can start to dissolve from the inside out as things start working there. So we end up having the potential there for that GI bleed. Couple things down there: typically if somebody's complaining of gas or they end up having gastritis, that's typically due to an inflammation of lining of the stomach that wraps around the fundus in the body of the stomach. Now, one of the things that goes along with that is H. pylori. H. pylori was found to be the cause of the majority of stomach acid issues, which is bacterium, but it's one of those things that was kind of the researcher who found it was not permitted to infect study subjects, so he infected himself, took two-week course of antibiotics, and actually cured himself of the H. pylori that goes along with that. But again, that can lead to gastritis. We end up having, along with liver issues, cirrhosis, or something known as esophageal varices. The esophagus tends on that inner lumen tends to be extremely vascular. And what ends up happening is the pathophysiology with this, majority of the time with esophageal varices, is because of the circulation with the hepatic portal system. What we end up doing is getting hepatic portal system backup, which then, as that blood backs up further and further, one of the offshoots directly off of that hepatic portal is going to be the esophageal veins. And as they start to build up, they get larger and larger and larger. And this can cause, if they rupture, then an individual has an upper GI bleed. They're bringing up very dark, clotty blood. Also, other things is hepatic cancer. Individuals who end up having cancer of the liver, this can also occur. And when these large varices break, there's really no way for us pre-hospitally to limit the amount of bleeding that is coming out of there. Most of the time they get to the ER and they'll end up sending a balloon down. Basically they'll take a modified endotracheal tube that's much longer. They'll go down with a camera, find out where it is, and they'll inflate a balloon to apply compression from the inside to try to get to that under control. There are times people can bleed to death from it, as well as airway issues do come along with it, because as these large, almost aneuritic type hematomas form, if they get large enough and the esophagus being very soft, without any cartilage around it, it can actually expand to the point where it can impede, if it is up high enough before the carina, can actually cause closing of the airway. But individuals that have active esophageal varices are really sick individuals. Some things that also go along, if somebody has been vomiting for long periods of time, you can end up getting what's called a Mallory-Weiss tear, which is a tear in the lower esophagus down here somewhere before the esophageal sphincter here, the cardiac sphincter here, it tears somewhere in it because of the throwing up, the regurgitation, severe regurgitation. This is why having ondansetron and or the Zofran available is very important, especially if you have someone who is retching for hours upon hours. They can, unbeknownst to them, throw up to the point where they actually rupture and tear the inside lining. We also have what is known as Borhave syndrome. And Borhave syndrome is basically where we get a rupture of the lower thoracic esophagus for whatever reason. Most of the stuff, Borhave syndrome, is typically due to genetic issues, but we can also see that, especially Mallory-Weiss syndrome and or Borhave's, a tear in that area secondary to trauma. So it's always important, if somebody is bringing up blood, we got to determine where it's coming from. Is it coming from the GI system, or is it coming from the respiratory system secondary to CHF or something like that? So it's important to follow this stuff up and along with that. When we start looking at the lower GI bleeds, and again, anything from the ileocecal, I apologize, from the lower portion of the duodenum, when we look at the gastric sphincter, anything from that point down, anything from the stomach up is considered an upper GI bleed. Anything below the stomach is considered a lower GI bleed. And again, it includes the duodenum, the jejunum, the ischium, and all that as we start going around into the small and large intestine with this. And again, the higher something is in the GI system, if it does come out through the lower system, it will be dark coffee ground emesis type blood. The lower you get into the GI system, again, hemorrhoids in the rectal cavity will be bright red blood. But again, a couple things that can go on here is diverticulitis, diverticulosis, the small outpourings of the colon. All right. Typically what happens is food or something like that gets into those pouches and starts to swell, which then, if those pouches do swell, they become irritant, they start to bleed. They limit the ability for the patient to be able to absorb their food. And then at that point, if that can get any worse, they can actually perforate, which then causes the stomach contents as it comes down through, or the chum as it comes through, as it's churning with peristalsis through the lower GI system. If you end up getting a perforated diverticuli, basically what ends up happening with those individuals is it can bleed out. It can then go into the walls of the stomach, and there it can become infectious, and it leads the patient to sepsis. So that's why it's always important to find out their history. Do they have a history of diverticulosis? Feel their stomach. Be nice to their stomach. Nice, gentle, full. If somebody has rebound tenderness, oh, okay, is that normal for them? And in the back of your head, oh, do you have diverticulitis? Do you have any type of foods that you can't eat? One of the things that individuals with diverticulitis try to avoid are seeds and or anything with nuts, because those are small enough they can go into those outpouring of the pouches. Also see their tumors, colon cancer in that can also cause problems as we move down around and through. We can end up having ischemic colitis. It's basically where, and it can go along secondary to diverticulosis. Tumors where basically part of the colon loses its blood supply. The mesentery in and around that area becomes limited for whatever reason, whether it's secondary to trauma, sepsis, liver issues, anything like that, can lead to ischemic colitis. And then basically with that, because of that, the large intestine basically is no longer able to absorb water. If you remember from your anatomy, the small intestine is where all of the minerals and electrolytes and food stuff is removed from the stomach contents, the chum that comes down through the small intestine. That's where everything's broken up, and that's where everything's absorbed into the body. Once all of that chum has now been taken care of, it now gets sent out into the large intestine. The large intestine's primary job is to remove the water. Typically, if you look at the ileocecal valve in the right lower quadrant, everything comes out very, 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 very liquidy, almost like a very fine pesto. But as it travels from the ascending across the transverse and down the descending colon, primary job of that colon is to remove the water. And with that, it ends up becoming, if you have too much water, not enough absorption, you end up with diarrhea. If you end up with too much water being reabsorbed, then you end up with constipation and hard stools. So that's something to consider with that as well. And with that, if you do have somebody that does have long-term ischemic colitis, those are the individuals that end up getting colostomies and having colostomy bags, which are only located on the left side. We can also have AV malformations where due to whatever pathology is going on, we can end up getting a cross-linking of arteries and veins put together. We've already talked about GI bleed. Everybody here that's worked in EMS more than 5 minutes has gone into those SNFs and or nursing homes 2 days before Christmas. It's 98 degrees in there because everybody's hyper or hypothyroid. They need some heat, and you end up smelling that warm blood. As my son is walking across from me, he used to work in a SNF and knows exactly what a GI bleed smells like. But these individuals are going to have black, tarry-like stools, very, very thick, very homogeneous, and it smells with that. They can also, on the upper GI side, they can get the coffee ground emesis. When you hear the term melena is the medical term for dark, tar-like stools, dark sticky feces that contains partially digested blood. This is why it's important if somebody's had stomach pains for any given amount of time, if it's an elderly individual or even a normal individual, ask them how their bowel movements are. And if they've had a recent bowel movement, if you have a GERI patient with a toilet next to their bed or in their bathroom, have they flushed it recently? Go and take a look. Estimate potential blood loss. With that way you can tell command what's going on. These individuals may experience orthostatic hypotension secondary to the bleeding. Typically, one of the things to worry about too is, especially if these individuals are on some type of blocker, beta blocker, or whatnot like that. Excuse me, I have to sneeze. Oh, excuse me. Sorry about that, guys. I'm having a sneezing fit right now. I'll be right back. Sorry about that, everybody. I don't know what happened. Apparently, I had to sneeze. One of the things is we start as you go out there, and once we start assessing these patients, please remember, low-grade tachycardia is one of those things that's the earliest predictor of somebody who is in some type of homeostasis, homeostatic having homeostatic issues. They again, cardiac output equals heart rate times stroke volume. That increase in that heart rate is going to be one of your predictors for that. So if they're above 100, 110 or something like that, and there's really no reason, start asking those in-depth questions regarding that. Other things that we could see, especially with individuals who take a lot of drugs that affect peristalsis, including diphenhydramine, as well as opioids, OC, or anything like that related for pain, is going to have a direct effect on the peristalsis of the lower GI issues. And again, things that can occur: tumors, recent abdominal surgery. That's why it's very important for individuals who've had abdominal surgery to pass gas and have experienced flatulence, as well as occasionally have a bowel movement, because it can cause a bowel obstruction. We also have vertebral compression fractures can cause neurological issues when it comes to normal peristalsis. Individuals that experience diffuse abdominal pain are complaining of bloating, nausea, potentially vomiting. And again, when we start vomiting, somebody unable to take something in very quickly, usually that means that there may be a bowel obstruction somewhere along the way. Do they have a distended abdomen more so than normal? And if you're any good at listening to bowel sounds, it's not something that we could do in the back of an ambulance. If they have hypoactive or absent bowel sounds, then that would lead to a BO, a bowel obstruction. If you look here at this x-ray here, this x-ray here does show these diffuse bowel obstructions that normally happen. So if you look here, I'm just going to put the spotlight over this. Okay, typically this is the patient's right. Here you can see it. So from the patient's right ileocecal valve here, you can see it would come up, go over, normally come down, and then come out through the rectum. But as you can see, this diffuse, these clumps right here, notice this is blocked up. This is not only blocked up in the large intestine, but this is also blocked up in the small intestine here, which we can see is dropped a little bit into the pelvic cavity. But again, here you can see this individual, one of the things that, and I hope that some of you have had this opportunity to do it in the ER, is assist with reducing impaction. One of the things that again, with the elderly that tends to be problematic is they do get bowel obstructions. How do we clear those? Well, manual relief of said obstruction. A lot of time it's usually accomplished with a soap and water, a tepid, slightly warmer tap water with a little bit of hand soap or Dawn dish soap. There's some stuff that's good for biologics, but basically all you do is you insert the hose up into the rectum and you allow the fluid to flow in. And typically once that's been, that fecal impaction has been broken away, everything will come on its way back through. You'll release it. It's just like releasing a hair clog in your drain at the house. Other times, maybe not. One of the best tools to release one of those easily, those lower GI impacted bowel obstruction is literally a spoon. You go in there, you have the individual hold the water in as much as they can, and then if it is that hard, it does feel sometimes like a rock. You would go in there with a spoon and begin to clean that until you got to something that was soft enough to where you could insert the tube up beyond that and help to stimulate the normal peristalsis and the movement of that impacted fecal matter. But again, what's going on? Here's one of those nice little memes I was telling you about. As we move along, this really smells bad too when you start dealing with that. These individuals can present to you very septic as well, because literally all of their solid waste that they had been gone through the digestive system is now sitting there, and it's becoming even more and more wretched as well as rancid. So that's something to think about as well. Check that stomach if it's hard as a board or something like that, and ask them, when was your last BM? And they say, oh, it's been about 2 weeks. Then you might want to, hey, we've got a bowel obstruction, and those individuals can get really, really sick really, really quick, depending on whether or not there is some type of fracture in the large intestine or even the small intestine. And if they are that bad, it might require a surgical fix on that. If anybody has any questions, go ahead and send them into the chat, or just go ahead and walk in for me. When we start looking around here, mesenteric ischemia, as we've talked about a little bit, basically for whatever reason, the intestine is not getting enough blood, which leads to an infarct. um, individuals that do have mesenteric ischemia do not do well. It's just one of those things. Mesentery, they have been working on transplants in and around this area, but it's extremely difficult. But these individuals here are going to have bloody diarrhea, tachycardia, abdominal distension, possibly bile obstruction. Think about that. But again, very shocky and risk of infection, sepsis. Other things that we can see that can cause problems in these individuals, as we've already talked about: appendicitis, right lower quadrant. With that, some other individuals, alcoholics, will suffer secondary to cirrhosis. With that, and ascites. Ascites is because of the ballooning of that hepatic portal system. What we'll end up seeing is all of the vasculature of the abdomen becomes pooling, and it gets much larger, like varicose veins of the legs. It looks much larger, fluid in the mesentery and all that other stuff that can go along with the cirrhosis. Other issue that we can get at, and again, it can attack and can cause problems across the age ranges, but one thing that we will see is individuals who suffer from cholecystitis. Cholecystitis is the medical term for a gallbladder that has ceased to work. And it could be for a number of reasons, whether it be secondary to gallstones, whether it could just be for bad pumping. Remember, bile ends up being an additive that is added to the duodenum to help break down fats. So we'll end up seeing somebody with this right upper quadrant pain, potentially with referring pain to the posterior, same location. Imagine taking an arrow and just pointing through it, as well as up to the right shoulder. But again, typically what will happen with individuals that are having gallbladder issues are, if they eat fatty foods, that will really trigger it, because your gallbladder wants to start pumping out this, the bile to help to emulsify all of that fat. Now, most of the time, if they have gallstones, if they have anything else like that, typically it's a surgery where individuals go in, laparoscopy, and they remove it. And then individuals are told to stay off any fatty foods for a while, but over time, the liver will actually start producing the bile as needed, rather than producing it to store it in the gallbladder, because basically the gallbladder is nothing more than a vessel, a cyst, a bladder, to be able to hold the contents of that bile as the liver would produce it. In absence of the gallbladder, the liver just produces it as it goes forward. Some other things, general term, peptic ulcer disease, as we talked about a little bit earlier with the upper GI bleed. We talked about H. pylori, but again, when we talk about PUD or peptic ulcer disease, we talk about a combination, almost like a syndrome. We get a combinations of signs and symptoms based on different types of ulcers and where they form. Here you can see there's just the stress ulcers. Okay, individuals who stress, drink a lot of coffee, smoke a lot, drink a lot of alcohol, typically those individuals will then cause damage to the lining of their stomach. You can get gastric ulcers. With that, again, secondary, individuals suffer from weight loss, because as they eat, the pain increases. So most individuals that do have GI problems tend to become anorexic because it hurts to eat. When we start looking here, duodenal ulcers, these typically tend to be most common, show up in well-nourished individuals. There's usually pain 2 to 3 hours after the meal, because the food actually, as it goes through the duodenum, actually is calming for it, because there's something there to cover it, rather than the pancreatic juices as they come out can cause problems. But again, common risk factors for everybody with peptic ulcer disease are going to be obviously the stress, as the H. pylori, as we talked about, increasing alcohol, as well as smoking. Some other issues that I covered here under GI were just the general terms of peritonitis, somebody that complains of a hot belly. it can be one of anything that's going along. We talked about the cholecystitis. We've talked about potentially with a appendicitis, bowel obstruction, anything that causes an issue with the tummy. One of the things that you also see if it's a bacterial or viral issue is going to be moderate temperature, greater than 100 Fahrenheit. Okay. Other things you want to watch out for, these are just general um, vital signs monitoring. These individuals are going to be tachycardic. Why? Because of the pain. It hurts. Increased blood pressure, normal stress reaction. But because these individuals, it hurts in their tummy, one of the first things that things do is it shuts down your appetite. So these individuals may end up having some dehydration issues. Up here, if you notice up there, they're going to say normal saline just to keep people hydrated. And then here they've added a little bit of potassium, because one of the things when people end up having diarrhea and or nausea with excessive vomiting is they're going to end up dumping a lot of potassium out. So as well as I do, potassium is one of the major electrolytes needed to make the heart work. So if somebody's throwing up enough, they can end up having issues that go along with that. All right, but again, you can read this and with that. Some other things that go along with our elderly individuals are going to be skin issues, botrytis, basically caused by dermatitis, eczema. Basically, somebody is itchy, scratch and scratch and scratch. Most of the time with the dermatitis like that, it is self-limiting, but if somebody scratches enough and a bacteria gets into that, it can then cause problems further on down the road, like we had talked about, susceptible bacterial infections, potentially fungal infections. Fungal infections are a whole another aspect of medicine. Funguses stick around a long time. Most of the time, we'll find fungal infections, in the form of athlete's foot, jock itch, which are exactly the same fungus. It's just depends on which location they're in, as well as a big one, especially with the elderly with a suppressed immune system. You find a lot of fungal infections in their ears, as well as if you have individuals that have poor immune system, as well as do not practice good oral hygiene. You can also get fungal infections in the mouth. And with that, that can also come down into the rectum and the anus as well. A lot of these, again, can be drug induced, as again, immune suppressives can do that. Chemotherapy, radiation, stuff like that can all add to all that stuff. One of the problems that we'll see with elderly is pressure ulcers, also known as decubitus ulcers. Usually develop from the waist down over bony prominences for individuals that are bedridden. One of the, in these SNFs in the nursing homes, people have to move. Even though people would say that they would love to stay in bed for excessive periods of time, you have to be careful of skin breakdown, especially with the elderly that don't have the calcium, that don't have the vitamin K, and the vitamin D, and their adipose tissue is very limited. These individuals, the dermal tissue can break down very, very much, and can lead to some really nasty infections, open sores. But basically, things that go along with it. Because an individual has an altered sensory perception, they don't know that they've been sitting too long. They don't know if they're laying too long. Having direct heat sources in a nursing home, right where someone could sit next to them, is very bad because they can't tell whether they're hot or not. They can get burnt, which then can lead to even further issues. Maceration is a big deal, especially with our ICU patients that are on vents in that manner because they're on paralytics. Even though somebody's in the ICU, please realize that those patients still have bowel movements as well as liquid, urine. Most of the time, the urine is controlled with a Foley catheter, but those individuals that will continue to have bowel movements, they have to be changed regularly. If not, they end up having to be given a rectal catheter, which they will allow a Foley bag to draw away any liquid, acidic liquid, as normally in feces. So that's something to think about as well. If you transport people back and forth, these individuals are going to see decreased activity, decreased mobility. They're going to have probably poor nutrition, as well as they're going to be subjective to friction or shear forces moving around and stuff like that. This can all, along with the maceration, can lead to a increase in these wounds. So these patients should be changed position frequently, even if they're bedridden. Every half hour, usually come in, put pillows under one side, lift a leg up, put sheepskin booties on individuals, get them up if they're able to walk, stuff like that. But again, we've got to be able to move them. And we should also, if there are issues with the individuals in sniffs or something like that, they should be at least 2 to 3 times a day be covered with some type of, here they refer to hydrogel, but honestly, Cervé or something like that, some type of moisture containing covering that will go over the patient's skin. That way the eczema or dermatitis doesn't kick in. That way there's an extra layer as they move over some type of tissues of bed linens. So here you can see here, this individual on the left-hand side, this individual has a horrible, horrible sacral ulcer. And this is directly related to laying in the supine position. Here you can see, here's the patient's right shoulder. Okay, they're on O2, you can see that, but they've rolled over. And here you can see this individual, because of laying there, okay, and the skin becomes reddened as it gets deeper and deeper as this, things push on it over the bony prominence, things start to break down until it gets all the way down to the muscle. And here you can see this is through the dermal tissue, and it's starting to actually get much, much larger, this whitened area, okay, in this blackened, darkened area, this necrotic tissue. This individual is going to need to stay on their side. They're going to end up having to have this area debrided, cleaned up with a bunch of antibiotic solutions, and then what will end up happening is they'll end up be put on a wound vac. These individuals are very susceptible to sepsis. If you look here where the rectum is, imagine if this individual has liquid stools, that now goes in there, the bacteria now, and so it's this ever arguing point. So that's why every patient, I told you from day one, every patient deserves a full secondary assessment. You may not be able to do anything with this in your truck, but if they've got a fever, their cardiac output's low, now you know why. You're finding, and now you can end up getting that reported. This patient, that's probably a 6 to 8 month issue of that closing. That patient's got to be moved. They can't lay flat for a very, very, very long time. Some other issues as we get older: osteoarthritis. Osteoarthritis basically is a breakdown of the joints secondary to arthritis, calcium disorders, everything else like that. General wear and tear, atrophy of the muscles that go along. Patients who are extremely obese ends up becoming osteoarthritic. Individuals have disorders of the overall joints, and it can be secondary from trauma. But if we look at this, osteoarthritis is one of those things in individuals that are 65 or older, our leading cause of disability in that time. Some other things that can go along with that: congenital abnormalities, joint pain, diminished mobilities, joint deformity, crepitus or grating sensation. As you get older, things just start slowing down. There could be tenderness or palpation or during passive motion. Ask that, if you start feeling somebody's calf and, oh, that hurts. Well, if it's the calf, is it potentially a DVT? Well, let's go down to the ankle, and you notice that they've had a lot of work down there. Well, maybe it's secondary to that. So, using your critical thinking skills and working around what's going on with that. Most of the time, this osteoarthritis secondary is to fractures of the hip, wrist, vertebral bones, compression injuries, individuals falling backwards. The old adage, help, I've fallen and I can't get up. Some of the risk factors that go along with this are going to be age. The older you are, the more possibility you're going to get this: gender, race, body weight, body type, as well as familiar history. And typically, this is osteoarthritis typically is one of those things where mitigation is probably mitigation and prevention is probably your best treatment at that point, where exercise and drug therapy, like calcium vitamins that help rebuild the calcium, and if there are some immune issues. Some of this osteoarthritis could be related to an autoimmune deficiency syndrome that robs, or your body white blood cells thinks that the cartilage at the phalanges is foreign, and they go and attack it. So there's a bunch of issues that can go along with that to help with the individuals. And as we talked about, exercise, get these individuals need to be out stretching. Could there be drug therapy? Could there be surgery? There's always some type of therapy out there to help with this. Ankylosing spondylitis. This is a unique disease. I find it unique in the fact that it is it's secondary to inflammatory arthritis that affects the spine only. It does not affect the extremities at all. It's just the spine. But over time, what happens is the joints between the vertebrae start to become calcified. All right. And basically what happens is over time, they become stiff and inflexible, and they end up fusing the spine typically because not only does things start to become naturally fused together with the calcification of the of the intervertebral discs, but basically to fix this, what they end up doing is going in there, doing a spinal intervertebral disc replacement, as well as starting to fuse the spine together to limit overall movement. And what we find out are these individuals become incapable of flexion, extension, or any type of lateral movement. And an example of this is if any of you guys are fans of the band Motley Crue, or watched the movie The Dirt, their lead guitarist, Mick Mars, found out very early in his late 20s, early 30s, that he had this ankylosing spondylitis. And here you can see him in the late 80s. He's, normal height, normal weight, but this disease started to affect his spine. And here you can see here, in these x-rays under the spotlight, here's the intervertebral discs. These are growing together, and they put you into that hunched over kyphotic view with that. But here you can see in this picture here, this is Mick Mars 30 years later on their Motley Crue's final tour. But he got very, very thin. And if you've ever watched his stage presence, he just stands in front of the microphone because he can't move. Because his spine has been fused almost all the way from this. He has to lay, once he's up, he has to have somebody help him lay down, but he can only move forward and backward in whatever way his feet can carry him because of this. His hands are still very, very active. He has no problems with that. But that's just an example of that ankylosing spondylitis. And if you want to watch The Dirt on Netflix or something like that, they discuss it a little bit. But if you watch the old videos from the early 80s, like Too Fast for Love or something like that, and watch their farewell tour back in 2017, 2018, you'll see they never put a TV camera up on because he's very sullen in and he doesn't move very well. He looks like the Crypt Keeper in reality when you look at it. Treatment for this is going to be fusing of the spine. These people aren't going to be able to move very well. They'll tell you what they can and can't do. But again, these individuals are going to be, if you ever take care of somebody with AS, airway, breathing, circulation, these individuals cannot be laid on a backboard. You got to put them in a position of comfort on the stretcher or something like that, and pad them, as we do with all of our patients. Another big issue that literally is a semester in med school or in any type of pathophysiology is the disorders of the renal system with the kidneys. Some things that go off, you'll hear the term ESRF, end-stage renal failure. That's where you get about 10 to 15% of your total Medicare, Medicaid money is going to, is individuals that suffer from end-stage renal failure, those individuals that are on some type of dialysis and or are on the list for a new kidney. But typically what happens is over years, secondary to some other type of disease state like diabetes or something, we end up getting what's called glomerular nephritis, inflammation of the glomerulus. We get renal blood clots. Basically, what happens is the kidneys can no longer filter out the liquid waste of our body. And as that happens, toxins build up into the body, which cause a multitude of other medical issues. So all this stuff leads to renal disorders. One of the terms that again we talked about was ESRD, end stage renal disease, also known as in a larger umbrella term is CRF, chronic renal failure. Now these individuals typically to get that term, a diagnosis of ESRD, means that their GFR, which stands for their glomerular filtration rate. Each nephron in your kidney has a glomerulus, also known as a Bowman's capsule. And that Bowman's capsule has to filter at least 15 milliliters per minute of GFR. Once you start dropping behind that, whether it's secondary to disease states of the nephron, loss of the kidney, anything that goes along with that, blood flow, the afferent to the efferent on that side, if there's anything like that, you lose GFR. If you end up having a renal disease or something like that, one of the things that they're going to talk about is going to start you on, giving you a lot of fluids, because the more fluids that you're able to put through your kidneys, the higher chances that it's going to keep working. Because once the kidney stops working, it's really hard to get it start working. It's a very hardy organ. In fact, we can actually harvest kidneys from cadavers. And that's in I think it was 1956, the first transplanted organ was the kidney. I think it was a cadaveric kidney. But once you start thinking about this, as the kidneys start going down, and down, and you're unable to filter things, basically these individuals end up needing dialysis. And dialysis comes in a couple different forms. One is the institutionalized version that I'm sure each and every one of you have seen ad nauseum. Excuse me one moment. Excuse me. But one of the things that we're going to start seeing in these individuals is going to be acid-base issues. We're going to start building up urea in uric acid in the body. We're going to start getting acid-base issues because we can't urinate out the acid. So we're going to become acidotic. pH is going to go down closer to 7. We're going to see increase in respirations because the body's going to try to take that CO2 off. These are the patients, if you get them into cardiac arrest, these are the patients that if they haven't had dialysis for 3 or 4 days, these are the individuals that may benefit from early on sodium bicarbonate administration. With that, but these individuals are the ones that get really sick really quick. These are the individuals that need 2 to 3 days of 5 to 6 hour dialysis. These are the individuals that end up getting shunts put in, AV shunts put in, to help facilitate being stuck with usually a 14 gauge, 2 14-gauge needles every week, 2 to 3 times a week. That's traditional dialysis. Another type is peritoneal dialysis, where they put a tap into the peritoneal cavity. This is more long-term issues. Individuals that aren't eligible for kidney kidney transplants may end up with these. But basically what they do is the individuals come home every night and they dump out what is known as the distillate that they had pumped in the morning before. And basically what happens is through the osmotic pressures and all that other stuff with this distillate into peritoneal cavity, it draws out the waste or the toxic substances from the mesentery, as well as the smaller capillaries of the digestive system, then comes out into the distillate, and then 24 hours later or 12 hours later, whatever it is, they put another empty side into it and they drain out the belly. And so that's the difference between traditional dialysis and peritoneal dialysis. So if you ever take care of a patient who's got a really large abdomen, and when you tap it, it sounds like there's a watermelon in it. Typically, look for literally, it looks like the tap of a keg that you could actually screw in a IV cap, and you could draw off fluid. Excuse. So again, these patients are going to become hypotensive potentially. We want to be mindful with a lot of fluid, because if they haven't had their dialysis, they can't urinate off all the fluid we want to give them. Right, left side failures. Individuals may also have post surgery become very septic. Um, they may undergo a lot of angiographic procedures to find out if blood is still flowing through the kidneys. They end up having nephrotoxic antibiotics. And again, that's something to think about too when patients are all on these antibiotics. While it's taking care of the bacterium, it may end up having long-term issues in more in-depth systems. But again, as we've talked about already, end-stage renal failure here is these individuals. One second, I'm trying to shorten stuff here. But basically, end-stage kidney disease occurs when chronic disease, the gradual loss of kidney functions, reaches an advanced state. In the end-stage renal disease, kidneys are no longer able to work as you need. And then that leads us to dialysis. So this was a chart that I showed that I found on the CDC website, and this is the percentage of chronic kidney disease among U.S. adults aged 18 or older, but it doesn't give us the reason why they're in kidney failure. Could be IV drug use, just general degradation, or something like that. But here we can see, 65 and older, that's where we're looking at almost 40% of the population. Here you can see 18 to 44, 45 to 64, a little bit more women more than men. But if you notice, non-Hispanic blacks are the individuals that suffer the more, at over 15% of that. But as you can see, it's in between that 10 to 15% range. So it is a big deal, chronic kidney disease. And we'll see more as the baby boomers progress to get older and older and over that age 65. One of the new things that's coming out is at-home dialysis, where instead of going to a facility 3 times a day, they come home, they plug into a dialysis machine that a home distributor has come in and cleaned, and they're literally drop-in filters now. They put that on, they plug in, they go to sleep. 8 to 10 hours later, they come back, they're completely dialyzed for the next couple days, and they can do it at home in the comfort of their own home. So just to go back here and review, looking at this individual's down here with the left kidney. Notice here you have the ureter. The ureter is the connecting tube that goes down to the bladder down there, and then we end up having what looks like a kidney bean, but we end up having the kidney, where we end up having the renal artery, and then the renal vein here, as well as the renal nerves located in the area of the anatomy called the hilum. That's this area right here that I'm outlining. With that, one second, let me get a pen. Okay, this area right here, this is known as the hilum. This is where if you get renal calci or anything else like that, they actually start forming in these little areas right in here. And then we end up having the afferent and efferent tubules, which end up going further out, because the further out, the less the osmotic pressure is, whereas you come closer to the hilum, you end up getting a higher osmotic pressure, which causes the sodium and potassium and the retaining of the water, along with follicle stimulus, some other hormones, will allow us to urinate out. But the kidneys, with the loop of Henle, and when we take our diuretics, loop diuretics, you can go back and review the anatomy of the kidney, and the loop of Henle changes the osmotic pressure between the sodium and the chloride as it's drawn out, and it allows us to urinate out even more as needed. But that's where that works there. Glomerulonephritis, inflammation of the glomerular area in and around that. Okay, and basically what this happens is as these become swollen, we end up typically as these become swollen, they end up releasing antibodies, usually from a recent strep infection. So strep that has gone septic and ended up going and settling in the kidneys, you can end up having glomerulonephritis. And again, signs and symptoms of these individuals are going to be high amounts of urination, which are going to lead to hematuria and proteinuria, where we're dumping not only blood but also protein out through the blood. Low-grade fever, overall lethargic, hypertension, headache. It can affect a lot around the body. One of the things that you guys have probably seen, especially in the elderly that we transport, are individuals that suffer from UTIs, urinary tract infections. And we see a disproportionate number of females getting UTIs than we do males, and that's due to the atrophic vaginitis, where we have the shortened urethra coming out from the vulva, versus where males tend to have much longer urethras in that manner, which can actually separate the bladder from the outside world. But also, one of the issues that we see as these individuals get older, in men, we get the prostatic hyperplasia, where the prostate gland gets much larger, which causes the urethra to constrict, which doesn't allow the bladder to completely empty. When the bladder doesn't completely empty, we end up with a UTI, and then that can lean back up and regurgitate back into the kidneys, which leads to pyelonephritis and all that, those other issues with the kidney issues. One thing that again, dementia and the whole system of neuro can lead to the UTIs. They forget, or they become comfortable with having a Foley catheter in. The Foley isn't changed regularly, or the Texas style isn't changed regularly. Individuals who are diabetic have a much higher rate of UTIs as well. And those individuals that are immobilized, are in bed all the time, much greater rate for all that, as well as those that suffer from CVA. As I said earlier, any neurological input can cause problems with that. We've talked about the bladder issues with catheters, urinary tract stones, where we get kidney stone, or not truly kidney stones, but because of the buildup of the electrolytes in the bladder or in the ureters that hilum, we can actually get renal calci, as well as other type of stones that are formed from minerals that are remained in the urine. And again, these individuals, when you go to do an in-facility transport, when you go see those nursing home patients, grab their urinary bag, their Foley bag, look at it. If it looks like chocolate pudding, more than likely they have a UTI, and they're probably septic. Drain it out. Never take a Foley bag with you that is full. That is a disaster waiting to happen. Drain it out, and while you're draining it out, take a whiff. Not a big whiff, but if it smells like ammonia, they're building up uric acid. And if there's particulates in it, same thing. So there's all these little signs that you can see when you assess your patients. All right. Most of the patients that suffer from what is known as urosepsis, secondary to UTI, okay, are going to exhibit fever, chills, possibly abdominal comfort, signs of sepsis. All right. And again, you can see individuals possibly leading down this road to becoming septic if they're within 24 to 72 hours after a catheterization or a cystoscopy. And that's where they take a camera, insert it into the urethra, and look up into the bladder. So anything that deals with that, you might high index of suspicion of septicemia. Treatment for this, airway, breathing, circulation, fluids, and get them to the hospital because they need their catheter changed, they need drained out, as well as they need wide spectrum antibiotics, as well as a, not only to start off with wide spectrum, but also to be able to go and get that, agar, they have to have that. All right, I'm drawing a mind blank here, guys. They end up having to have cultures drawn and smeared to figure out what the actual impending bacterium is that's causing all these problems. And here you can see just another mem um, talking about cystitis, as well as if there are, as you get older, with the prostrate hyperplasia. Some other issues that we're going to see is renal compensation in shock. Remember, as we start to, when our body begins the trauma, when we're actually sanguinating or bleeding out, one of the things that we want to stop doing is urinating. So with the increase of what's known as ADH, antidiuretic hormone, we're going to see patients with fluid retention. And hopefully you saw that in a little bit of the shock patients. We saw them in the patients with burns, where once a patient gets burned, 8 to 24 hours, we're going to see this huge swelling because there's been cellular type of damage. So we're going to see an increase in ADH, and patients are going to retain their fluid. That's something to think about as well. If you have a patient that is elderly and has had recent trauma and states they haven't been able to urinate, please realize that there may be an increase in ADH and they're retaining fluid to keep their pressure up. Look at the tachycardia if they even have it, and try to figure that out, because all of these little hormones on the back end are really, really, really starting to affect the patient along the way. Other things we got to worry about, patients that are exposed to the environment. Accidental hyperthermia it can run rampant, especially when these elderly individuals are on fixed incomes and they can't afford the oil bill or the heat bill, the electric bill, or something like that. So while they're covered up in extra clothing, a day of 70 degrees outside, if they're in a dark room or something like that, can lead to accidental hypothermia. Please remember that the thermal gradient between 98.6 and a normal 70-degree day is almost 30 degrees. So that can cause a lot of problems, because as the individuals get colder and colder and colder, they potentially have confusion. They'll start shivering, and most people, shivering is a normal reaction because your body starts getting cold, so you want to increase your temperature, so you start shivering. Just like when you have a bacterial or viral infection, shivering increases your core temperature. Problem is, most individuals, once they start the shivering or they start feeling cold, they end up taking some type of Tylenol or ibuprofen to lower their fever. Well, guess what? Shivering goes away. Now they're not able to keep as warm. So be mindful when you see some people taking Tylenol and or ibuprofen and they're not shivering anymore. Individuals, hypothermia can experience what look like to be stroke. Signs and symptoms with the aphasia and the dysphagia. Individuals may be overtly asleep or they complain of stiff muscles, as well as anything else that's going on. Do they have an AV shunt, which increases the heat loss because the blood actually comes above the skin? Do they have any chronic illnesses, drugs, CNS disorders, or endocrine disorders, like those hyper or hypothyroid issues that we talked about earlier? And again, with the elderly, we'll see they have forced inactivity, sit in his chair, don't move, anything else like that. Inflammatory dermatitis, and we've already talked about the income, the socioeconomic aspects of that. On the flip side, we have hyperthermia, the heat stroke. Okay. Typically, on the outside, once you start getting above that 98-degree mark, the individuals, and again, depending on the type of medications they're taking, they can't maintain their thermal gradients very well. Other chronic illnesses, like individuals with alcoholism, they can't, because it is a depressant, it depresses their thermodynamic abilities of their body. As well as you get older, you decrease your total amount of sweat glands. As well as, are they in a house that doesn't have air conditioning, a small, tin roofed house or something like that, or are they homeless or something like that? They cannot mitigate the increasing the heat. Especially, don't forget about humidities. The higher humidity, the harder it is for somebody to sweat. So these can all lead to heat stroke with that and heat exhaustion, as you can see here. You would hope that the patient is increasing fluids, but maybe they not. Maybe they're just sitting there. Maybe they're sitting there drinking alcohol. I will tell you from a personal standpoint, my in-laws right now, I think, are drinking 3/4 of western part of the state out of alcohol. I'm doing a run Wednesday to Maryland for my in-laws because this whole quarantine, they've started to take up alcoholism, I believe, as a third career. But all these things do go hand in hand. So be mindful of all that when you see and start assessing the elderly patients. And again, this is just reiterating what we just talked about. And again, hyperthermic or hypothermia. Again, make sure everybody's got enough fluid. They're not dehydrated. Reduce the activity. For the elderly patient that is hypothermic, bring them into the truck, turn the heat on, put hot packs into the areas where the arteries and veins come in close contact with the skin. That's in your axillary, your femoral region, as well as your neck. But you don't want super hot to where you burn them. All right. And if they're too hot, do the same thing, only with cold packs. One of the best things to do for these individuals is, if they're too hot, is to open them up to the ambient air, turn on the air conditioner, and let natural air move over them. This goes with any environmental thermic injury secondary to heat or cold. All right. Toxicology with individuals here. Typically what you'll end up seeing is toxic ingestions are accidental, in that fact where they forgot they took their medicine 2 hours ago. Let's take it again. Oh, I took one, two might be better. I'm really, really sore. I'll take an extra one of that. But there may be intentional. So you have to ask those patients, hey, by the way, did you want to hurt yourself? But again, due to the slow absorption and elimination, our bodies, as they get older, build up a much higher floating, I can't remember the name right now, much higher, not therapeutic dosing, but I'll get it for you. But basically they have too much of the drug in the system because it's not being eliminated as quickly as it should have been. And again, knowing what your patient's taking, get a good list. All right. Make sure, ask them, have they taken, have they gotten them refilled? Hopefully the patients are taking them appropriate, or their caregivers are taking them properly. A couple of the main ones that we'll see here, beta blockers, the ones that live OL, end in OL, labetalol, esmodol. All right, typically used to treat hypertension, angina, as well as cardiac arrhythmias, as well as to decrease the heart rate. But again, please realize individuals that are taking a lot of beta blockers, okay, are going to have the ability to change the tachycardic if they need it. All right, they may end up suffering from orthostatic hypotension. But again, if we end up with beta blockers, find out what they took, how much they took, and as they progress through, a little bit of fluid, airway, breathing, circulation, a little bit of fluid, and treat the cardiac anomalies as they come up. And again, when we're going to do this, finding out what they took, because if it's within an hour and the stomach has low motility, one of the things that they can do in the ER is do a gastric lavage with that. But it's very, very difficult. It's very traumatic to the anatomy. But it's one of those things. As we talked about, taking care of the cardiorespiratory support, all right, and then the non-adrenic inotropes, whether that be dopamine or dobutamine, most of the time. When individuals take the antihypertensives or diuretics, typically what we're going to see in those cases is increased urine flow, which is going to cause the water and sodium to come out. Individuals can become very dehydrated very, very quickly. They can become hypertensive as well, which leads to congestive heart failure, which then can lead to postural hypotension, circulatory collapse, retaining of potassium. Depletion of the potassium because of the urine going out, and then the renal system going along. Somebody who's taken ACE inhibitors, but basically their ACE inhibitors are used for hypertension and congestive heart failure. But again, if you end up having somebody that's overdosed on ACE inhibitors, they're going to become hypotensive, and they're going to have they're going to go into heart failure secondary, and you're going to have to do cardiovascular and respiratory support on that. To fix this, plasma volume reduction, most individuals, nausea, vomiting, diarrhea, as well as potentially dialysis when we start looking at the ACE inhibitors. DIG, typically DIG, Lennox, and digoxin are used for individuals with AFib. Overdose for that, again, get them to the hospital, treat for any type of shock that goes along with it. But again, getting a good long history and a list of all your medications can only help. All right. But basically, if they get DIG, foxglove, they need to go to the hospital, and they need to be monitored for a long time for that to monitor basically the low potassium, the hypokalemia, and they may end up on a potassium drip secondary to that. All right. We already talked about if we can get to it soon enough, a gastric lavage, potentially with activated charcoal. Years ago, we used to have, in our scope of practice, we used to be able to give activated charcoal along with syrup of ipecac to help people bring that stuff up. But that became an issue when we realized, hey, wait a minute, giving somebody that's potentially going to go unconscious this large black medication to bind to, whatever they've taken, as well as then let's give somebody a drug to vomit, ends up becoming problematic because now they have an airway issue. So it's kind of one of those things that have been taken with a grain of salt. Maybe, maybe not. But if they end up lavaging an individual, that's easier because all you're doing is you're sedating them. They're probably intubated, and you just put this large garden-sized hose tube down their stomach, flush it with fluid, get all that out, and you end up putting some charcoal in there, which will then bind in the carbon matrix to whatever toxic substances, and you lavage it again and bring it out. And again, when we start seeing these, because it'll cause bradycardia, we treat the bradycardia and any ventricular rhythms that we see. Anticoagulants, taken en masse anymore. Low dose aspirin, 81 to 325. Usually the AHA recommends anybody with a familiar history of any type of cardiovascular issue should be taking low dose aspirin, anywhere from 81 to 325 a day to decrease the possibility of having a DVT and or some type of embolic emergency. Other ones that you may see, the Warfarin, the Coumadin, they are difficult to dose to find what the therapeutic level is for that. But the nice thing about, well, if there is a nice thing, looking at the new stuff, the Pradaxia, Xarelto, Eliquis, the old Warfarin and the Coumadin can be reversed. You give vitamin K to reverse the actions of Warfarin or Coumadin. But when you start dealing with somebody who's actively bleeding secondary to the Pradaxia, Xarelto, and Eliquis, there is no available reversal agent out there that I'm aware of at this time. So if you have somebody that has is having a hemorrhagic stroke, and they're on Warfarin/Coumadin, you can give them some vitamin K. That'll eventually stop and the bleeding and clotting. But if you're on the other stuff, you're kind of out of luck when it comes to that. Antipsychotic, antidepressants, name it, from your antipsychotics on down, all the way up from, say, Effexor up all the way down up and through lithium. There are so many classes out there, MAOs. There's so many out there, methamphetamines, everything. So it's very important to try to figure out what they're taking or what they haven't taken. If you take care of an elderly patient that has a history of depression, that has been on Effexor, EFFXOR, XL, any of the formulations, and they haven't taken it within 24 hours, it may seem like they're having a psychotic break. So be mindful. Ask them when they took something last, or did they take too much of it? And so that's very important to figure out. Lithium toxicity. Lithium is an oldie but a goodie. It has been around since the 1800s, and it's been used to treat psychoses that no other drug would treat. It is a heavy metal, and it can create some lithium toxicity, but when all else fails, having worked in the MHMR group, when none of the newer antipsychotics or any type of antidepressants worked, and they were really that bad, and they needed something, lithium always seemed to work. So just be mindful if you get an older individual or something like that, you see something like lithium carbonate or something like that, just know that that individual is taking it for some type of psychological issues, and when did they last take it? And again, regardless of all these ABCs are going to be your primary. Parkinson's disease. When we start looking at Parkinson's, again, it's a neurological disease. Basically, what happens with Parkinson's is the dopamine secreting neurons that are located in the basal ganglia have started to break down. And basically, what they found out with Parkinson's is it is a dopamine dependent disease. In that manner, because dopamine is a neurotransmitter, and those Parkinsonian shakes that individuals get, rigidity, bradykinesia, the tremors are all due to lack primarily of dopamine in the system. And no, just giving cardiac dopamine doesn't fix it. This is a long-term issue. But again, the treatment for most Parkinson's is going to be giving more of whatever neurotransmitters are missing. Most of the ones I'm familiar with are the dopamine ones. But again, regardless of what we do in the field, just decrease their anxiety and whatever is going on. 9 times out of 10, you were never going to be called to a facility or to a house because someone's having a Parkinsonian shake breakthrough. Somebody may interpret it as a seizure, or something like that. But if you're not familiar with it, that's something to read up on. Anti-seizure meds, whether they are your benzos or whatever, Depakote or anything else like that, please realize that these are naturally depressives. It's important to know whether or not someone has taken their medication on a recurrent basis. Did they skip one? Did they have breakthrough seizure? Are they sleeping well? Are they keeping up on their normal schedule? Because that's something with somebody that does have epilepsy or something like that is on long-term anti-seizure medication. If their normal functioning day schedule is manipulated in any way, they can very easily start throwing seizures. Treatment's going to be airway, breathing, circulation, monitor everything that we normally do. Analgesics, anti-inflammatories, overdosing of your NSAIDs or your Tylenol, they have long-lasting CNS issues that go along with that. When you start getting into the opioids for analgesia, whether it's your Tylenol with oxycodone, your hydromorphones, or everything else like that, be mindful of what the patient's taking. And if you think there's a potential there for a narcotic OD, then potential to treat that with Narcan. And again, you don't forget about treating with Narcan. Treat with Narcan based on the respiratory drive. Don't just slam 2 to 4 milligrams and say, ooh, wind them up and let them go. Because don't forget, why were these patients taking an analgesic, an opioid analgesic to begin with? More than likely was for pain. And now all of a sudden you have slammed a reversal agent into them. They start reversing from whatever they were in. Now that pain comes up like a hot poker as well. And now your patient is combative. So, TLC when it comes to that as well. Things that go along with taking too many of the pain meds, again, orthostatic, drug tolerance, physical dependencies. But also, after a while, your anti-inflammatories as well as your Tylenol, they're going to cause gastric irritation. So if you find out somebody's been taking, indomycin or Toradol orally or ibuprofen or anything like that for long term, please realize that rips up the stomach wall. That can lead to peptic ulcer disease, gastric inflation, gastritis, all that other stuff. Corticosteroids. Corticosteroids are typically given for individuals that have osteoarthritis or some type of RA or inflammatory condition that goes along with it. Usually they'll get shots in the general area of the pain. I've known some people that have just gotten mainline corticosteroids, but basically they're being given there to help with the pain. But side effects are going to include hypertension, PUD, problems with diabetes, increase in glaucoma, increase for the potential of infection, usually around the injection site. But if you already have a infection somewhere, this may increase the amount of time that it takes for the injury to heal itself. All right. We all know about substance abuse. I don't need to belate this issue. Just because somebody's getting older doesn't mean that they don't still like to partake in certain substances, whether it be alcohol, nicotine, caffeine, or any number of those things. And as individuals get older, remember the time in front of an individual as they get older is much less in front of them than what used to be behind them. So they may have to deal with all of these things. So they may end up, retreating to um, alcohol or whatever type of substance they prefer. All right, we've talked all about all this stuff already. Polypharmacy. Again, polypharmacy, if you're drinking a lot, you have short-term memory issues, and you're also diabetic, you may have forgotten that you took your insulin already today, and you as the EMS professional end up getting a call to come treat a diabetic. Well, why? Well, it's because they took triple their amount of insulin today because they kept forgetting that they had already taken it again. So all this stuff can add in together. And don't forget, while we talk about drug-to-drug interactions, don't forget about over-the-counter drugs, as well as natural herbal substances, essential oils, all that stuff that some people do have a belief in. We may not have to agree with it, but we do have to treat and have a working knowledge of all that stuff. And again, if we have individuals with substance abuse issues, decreased vision, hearing, drowsiness, they may fall a lot, memory changes, mood changes. All these can mimic organic brain syndrome or anything, or just be part of getting older as well as your orthostats, all the way down to your weight loss. We've already talked about alcohol abuse, cirrhosis of the liver, organic brain issues that go along with that fall, and everything else like that. But again, one of the issues that we need to worry about, and it becomes there's usually always one question on your National Registry when it comes to alcoholism and how do we treat it. One is look at your glucose level, but also consider giving thiamine or B1 in the field. Pennsylvania doesn't do it, but it's one of those things that will just show up. It's still in the national educational curriculum, but again, treating for, quote, alcoholism is going to require thiamine. But also, please remember, alcoholism, individuals having DTs or anything like that is a true medical emergency. Not unlike opioids, which again, somebody going through withdrawal of an opioid will get the DTs, will get withdrawal symptoms, but they won't die from it. Individuals that are suffering from alcohol withdrawal can possibly die. All right. So all that. Some other type of thing I just popped up here for you guys to review in your free time is lidocaine toxicity. Again, if individuals are taking oral versions of lidocaine at home, maybe something for you to review. Now, the one thing that you could realize too, there is we had talked about this. I think Sam B, you had brought this up about giving lidocaine for individuals with refractory epileptic seizures that are unresponsive to benzodiazepines. And I think there is a small dosage of lidocaine just before you get to the overdosing stage, where it will has potential for decreasing seizure activity in the brain. So that's something to remember too when you're thinking. And then there's MAO inhibitors, monoamine oxidators inhibitors. But again, if you end up having somebody that's overdosed on Nardil, Paranate, or Marplan, or anything else like that are showing any of these signs or symptoms, okay, you don't want to give any barbiturates, don't want to give any TCAs or any of these things, okay? Another overdose poisoning that you may want to be mindful of is salicylate poisoning, TCA poisoning, usually coming from aspirin. Somebody overdoses on aspirin or something like that. Toxic level for a child at a 30 pounder is 12 adult aspirin or 48 baby aspirin. But again, please realize if you have somebody that has a potential kidney issue that's still taking aspirin or accidentally took 2 or 3, please be mindful. That's something to be monitored, especially when it comes to the tinnitus, the ringing in the ears. We've already talked a little bit about your psychological issues, whether it be anxiety or depression. Um, you know, just realize that these individuals have a whole lot of stuff going on in their lives. Look where we're at right now with the whole COVID issue. So these are things to be mindful of as well. If you ever get a chance, I highly recommend that you know what the DSM-5 is. DSM stands for the Diagnostic Statistical Manual, 5th edition. It's published by the APA, the American Psychiatric Association. And what it is it is the textbook manual that healthcare providers in the psychiatric field use to diagnose psychological psychiatric issues. There are various levels of things. I highly recommend you getting a copy of the old DSM-4 and just literally perusing it to see how individuals meet certain criteria for certain things, whether it's an affective disorder, a depression, okay, or a dissociative, a paranoid schizophrenia, organic brain syndrome, as well as personality disorders, or as well as your Alzheimer's, or anything else like that. That's where all of this information can be found. I highly recommend you go and research that. Some other things, and we've talked about this, lapses in memory for the elderly, cognitive difficulty as you get older, sleep patterns change. They have an inert fear of death. I mean, I don't know anybody that wants to die. As they get older, changes in sexual interest. Again, because all the hormones are dying off, whether they're progesterone, testosterone, all that other stuff, they go down. That ends up becoming loss of sexual interest. Thoughts of suicide do increase. I told you guys all that story about my wife's grandmother who wanted to know all about the out-of-hospital DNRs. She wasn't suicidal. She just wanted to make sure that at 95, somebody that's doing their job doesn't do their job, or makes it easier to not deal with things. And one of the hardest things is that withdrawal from society. That's something that we're seeing now with the physiological and physical distancing that we're seeing. A lot of the elderly are having problems with that. We've talked about depression, sadness, despair, crying, past PTSD, past psychological treatment in that, current stressful events, sensory changes. But again, always ask them, do they have any fear of harming themselves or harming others? That self-loathing or nothing can turn into homicidal homicidal ideations. Individuals can also experience hypochondria. They can also have the dysphoric pain and emotional pain. But again, ask them the questions. Be nice. Hey, you ever thought about this or that? If you're in their home, talk to them. This is where the CP stuff comes in really well, because the access to the socioeconomic and the therapies that are out there, whether it be psychotherapy, whether it be medical, or getting access to actual therapies with the psychotherapy. Nowadays, most psychologists are going to the phone, are doing web chats, they're texting. Or if they want to go and, when there is no more social distancing, can you get granny ride or grandpa ride? Can you get Uber and Lyft? Those are all things that can come along. And we see an increase in 911 calls during these times as well, because people just get bored and or lonely. As far as suicide goes, suicide has the highest rates in the U.S. in men over age 65. because again, it's that whole over 65 loss of certain things, loss of a spouse. It's just easier financial um, issues that go along with that. Okay, there's your financial problems. Elderly equate for about 20% of all suicides, depression leading cause. A lot of the individuals are bereavement for long-term partners. They suffer from chronic illness. It's just easier, they believe, to not be a burden on their family. Is there a family history of suicide? While there is a definitive list with individuals who do commit suicide, are there overt family issues with that? Financial problems, isolation, loneliness. Um, Elderly, some of them have problems with living in a youth-oriented society. Low serotonin levels. They don't sleep well. Without sleep, body can't heal itself, and typically that will lead to paranoia, physical impairment, substance abuse, and individuals live in unrelieved pain. Because again, our behavior in this idea is related to stress, because they lose interest in all their activities. They don't go out. They lose interest in grooming or their overall self-care. They don't want to do their medical or exercise regimes. General depression, individuals, even young individuals, grieving a personal loss, as we talked about earlier, the bereavement, um, um, an overall feeling of uselessness. If an individual all of a sudden starts putting their affairs in order, giving things away, or finalizing their will, have a question about suicide. We had that discussion with my mom with everything that was going on, during her last couple months, ultimately not being suicide. Um, Now, if an individual if you find somebody stockpiling meds or lethal means of self-destruction, if you guys like Amy Schumer, in her 2015 movie Trainwreck, her father um, was suffering from a neurological disease, was in a nursing home at an early age. He had ended up stockpiling all his meds. Even though the nursing home staff would give it to him, he would stash it underneath his tongue, take it out, leave it, and then after he ended up getting enough put away, he ended up taking a massive dose. So that's something to consider as well. People that are, hell bent on doing something are going to be doing it. So look for different ways, keep your ears perked at all those times. Remember higher incidence among terminally ill, especially your cancer patients when it comes to suicide. There can be intervention by society, from family to EMS to everybody. But again, ultimately protect yourself, protect patient from self-harm. If you ever want to do a good article, you could Google, I'll have to get it to you. But there is talking about suicide bags, where in New York City, hey everybody.